All right. So we're going to talk about carcinoid syndrome, a little play on Wizard of Oz here. I was feeling creative. I didn't use AI for that either, by the way. So I feel like we have to have that disclaimer like for everything now. Anything creative that I think of, that I have to say that I didn't attribute it to AI. But I did use AI for that image in the last one. Okay. So historical perspectives of carcinoid syndrome, first described in 1890. I always like to provide some historical context. These really smart, observant doctors back in the day who didn't have all of these special fancy tests that we have. First described what we would later know as carcinoid syndrome. So they said, well, we have this patient with something that started in the small bowel. They called it carcinoma at that time, but we now know as then they evolved to carcinoid, and now we've evolved to neuroendocrine tumor, who experienced diarrhea and shortness of breath after eating. So they would get this surge of serotonin after the gut got activated. It would flood the system, and they would experience the symptoms that we would later know as carcinoid syndrome. So why does carcinoid syndrome happen, right? So the neuroendocrine cells are specialized cells, and they make hormones and proteins, right? And so normally, when these cells are in what we call homeostasis, when they're functioning normally, they produce the hormones, but they're in balance in the body. So cancer, by definition, are cells that are growing unregulated, right? And because of that, you have more of these cells, and you have more of these hormones, right? And the hormones, again, flood the system and cause symptoms. The most common hormone that we talk about is serotonin. We measure that as 5-HIAA. And I won't quiz you on the whole description. You won't quiz me either, because it's a mouthful. Essentially, that's the metabolite, right? So after your body metabolizes serotonin, the metabolite is 5-HIAA. It's better to measure than serotonin because it's a better kind of average of the levels. The serotonin can fluctuate more, so I don't. Okay, I'm back on. Yeah, all right. So serotonin is the one we talk about the most. The metabolite's 5-HIAA. It's accurate to measure over time. But look at the list here of the other potential substances that the cells can secrete, right? And all of these can wreak havoc on the system, right? Histamine, norepinephrine. So you'd imagine the carcinoid syndrome that we usually describe, the flushing, the diarrhea, the wheezing, you could develop a host of other symptoms, right, that are outside of that, what we call triad. So
test, check. Swap the baton. Thank you.
Yeah, no worries. All right. So what I say is that, okay, flushing's the most common, diarrhea is the second most common, wheezing, we don't see that often, right? And then it can affect the heart valves, right? The serotonin directly affects the heart valves on the right side of the heart typically, because you'd imagine the exposure of the serotonin, it's exposed on the right side of the heart because blood is pumped from the right side of the heart to the left side of the heart. So that's why the right side of the heart is affected. But here are symptoms that I've seen patients have that are not carcinoid syndrome symptoms, right? So a patient has a neuroendocrine tumor and has symptoms, right? And you say, well, they're not within the triad. It's not flushing, diarrhea, and wheezing. Well, guess what? It's likely still related, right? Headache, anxiety, blood pressure issues, abdominal pain and cramping, hives and itching, nausea and vomiting, among others, right? So just because it doesn't fit into the triad doesn't mean it's not related. And I think your healthcare provider just needs to keep an open mind. Maybe you didn't read it in the textbook, but clinical experience will give you the knowledge to know that not everything that you can learn about medicine is in a textbook, right? Or even online. So about 20% of patients with neuroendocrine tumors will have carcinoid syndrome. We talked about that earlier, Dr. Data. However, up to 50% of patients with low-grade neuroendocrine tumors of the small bowel will have carcinoid syndrome. I think that's a little high. This was based on a publication by Dr. Halperin, who's over at Emory with Dr. Graywall. I think 50% is higher than I see in my practice. It's probably more like 25, 1 out of 4, I would say. But, when you're doing database evaluation, sometimes we overestimate or underestimate. We do not see carcinoid syndrome in neuroendocrine carcinoma, right? So the more aggressive neuroendocrine cancer that we see, neuroendocrine carcinoma, we do not see carcinoid syndrome. Maybe some case reports, but I've yet to see it. All right, so how do you identify carcinoid syndrome in terms of measuring blood or urine? So there is a 24-hour urine test. We talked about 5-HIAA, but there's also a blood test that got rolled out maybe 7, 8 years ago. And the data shows that it's just as accurate, right? So I don't have my patients carry around the jug for 24 hours and put it in the fridge and get mistaken for apple juice. So the plasma is a one-time thing. You just check it and, So what I tell patients is, particularly diarrhea. Diarrhea is hard to sort out in neuroendocrine tumors, right? Could it be carcinoid syndrome? Could it be pancreatic exocrine insufficiency, which we talked about? Could it be related to a previous surgery? Could it be bile acid diarrhea? I mean, that's 4 big potential causes right there, right? Well, the 5-HI is super helpful. In carcinoid syndrome diarrhea, it's got to be elevated, right? So if you have diarrhea and you get a 5-HIA and it's not elevated, it's not carcinoid syndrome, right? It's one of the others, right? So, but for flushing, trickier, because the older data from like the 70s shows that 5-HI doesn't necessarily correlate as well with flushing. So flushing's a little trickier. We think it might be some of those other substances that I showed you that laundry list of. It might be one of those. Chromogranin A, I'm just going to go out and say it's not helpful, right? Particularly in carcinoid syndrome, right? We could talk about it for monitoring disease otherwise, but for carcinoid syndrome, I don't know why somebody would be checking it personally. All right, so this is what the flush looks like. I'm telling you, you guys tell me if you experience it, but it usually affects the face, the neck, the upper chest, usually lasts from 1 to 5 minutes, and these are the ones that are typically related to the small bowel neuroendocrine tumors. Now, with that being said, one of my patients that had the worst flushing I've ever seen was a lung neuroendocrine tumor, right? So it's not just small bowel, right? There's some of the other flushing that you could see in the face. Sometimes folks that have had flushing for a long time can have these dilated blood vessels called telangiectasias. So they're little pools kind of blood vessels that from chronic dilation of the blood vessels. All right, the diarrhea, I've had patients have it really severe, up to 10 to 20 times a day. Luckily, with some of the new medications, that's not as common. Diarrhea is watery, can be explosive. One of the features also that it occurs at night, so it wakes somebody up that they have to go have diarrhea. The big thing with the diarrhea is it certainly is a quality of life effector, right? So that's what we talked about, quality of life. This can be really debilitating. So we should be aggressive in our management. So here's the list that we talked about of other causes of diarrhea outside of carcinoid syndrome. I think it's really important not to just attribute diarrhea to carcinoid syndrome. It should be evaluated systematically, meaning by process of elimination, right? Wheezing, not very common. Again, what I want to point out here is not serotonin mediated, right? Other of these substances that are secreted, it's mediated by those. So measuring a 5-HIA and you're having wheezing, it may not be elevated, right? So you have to think outside, your physician has to think outside the box of it could still be carcinoid syndrome, right? The one that's directly correlated, diarrhea. Carcinoid crisis. Somebody had touched on this earlier, but so it's sometimes misclassified. So if somebody has to go to the ER, they're having really severe flushing, diarrhea, that's not really a carcinoid crisis. What I describe that as is a carcinoid attack. Essentially, just the symptoms are unrelenting. A lot of patients will require an octreotide drip, which is essentially the medication that you would get once a month, but in an IV drip form, so that you just get a continuous exposure to it. Carcinoid crisis in the medical literature is actually related almost invariably to undergoing a procedure or a surgery. So they manipulate the tumor and the substances spill out in a very large amount. And this causes the blood pressure to go down, right? I have actually seen a patient develop life-threatening carcinoid crisis from a liver-directed therapy, so an embolization procedure to the liver. So you knock off the blood supply to the tumor dies and spills all the substances into the circulation. So your team needs to be aware of this risk, and how do you decrease the risk? Well, a lot of times I'll recommend some octreotide right before the procedure, right? Sometimes in a drip during the procedure. But the take-home point that your team needs to know about is if you develop low blood pressure, they need to give you medications to increase your blood pressure, not more octreotide, okay? We learned that more recently. All right, so why do somatostatin analogs work? All right, so earlier I said that these drugs make everything kind of lazy. They slow the gut down, they slow the gallbladder down. So essentially, when the drug binds to those same receptor that we've been talking about, Dr. Narav had pointed out the receptor very nicely on his illustration. When it binds, it sends inhibitory signals through the cell. The inhibitory signals say, hey, all that hormone that you're secreting, stop, right? That's how the drug works. It reduces the secretion of the hormones by sending inhibitory signals into the cell. So here's that receptor that we keep talking about, the somatostatin receptor, and here's some fancy molecular biology for all you molecular biology fans. All right, so telluristat ethyl, or Zermello. So this is an oral therapy. It was approved for patients who have diarrhea despite being on octreotide or lanreotide, right? So you're on your shots, you're still having diarrhea, this is the drug for you, right? I would say the only bummer part about it is it's a 3 times a day medication. I could barely take something once a day, so that can be a struggle. You have to set some timers on your phone. But the data clearly shows that it reduces the amount of diarrhea, which, as I mentioned, it also will affect your quality of life, right? So this drug improves quality of life. We don't know if it alters how the neuroendocrine tumor behaves yet, so we're still trying to investigate that. So this drug, paltusotine, Dr. Chauhan can pronounce it better than me. He's been involved in a lot of the studies with this drug. So this is an oral version, once a day, of the somatostatin analog. So the injections that you get once a month, they can hurt. We talked about injection site reaction. This may be a nice alternative, a once-a-day pill. I would be interested to survey the group here to see who would prefer the needle versus a once-a-day pill. So the needle once a month versus once-a-day pill. Who would go with the pill? Okay. And who would go with the needle? Okay. So more for the pill, but a few still for the needle. But hey, it's nice to have options, right? So this is being studied in a phase 3 trial, so stay tuned, right? And then one of our other supporters, Cameras, that drug, CAM 2029, also we're going to report out some, how it manages symptoms. That's the one that you could do at home, the injection you could do at home. So that's another option. It's nice to have options, right? Your physician, your team should talk to you about options so that you can make the decision that's right for you. So here's some pearls for maneuvers for carcinoid management. The addition of a short-acting somatostatin analog, such as octreotide, the one that I said you could put in the drip form, You can give it subcutaneously up to three times a day. It's got to be refrigerated. You got to usually pull up the syringe. It's cumbersome. Not an ideal way to manage carcinoid syndrome. You could increase the dose or the frequency of the octreotide or lanreotide. None of those maneuvers got FDA approval, but they are in some of the guidelines, so that's one thing. Managing the diarrhea with Lamodal or Imodium. Lamodal's the prescription strength one, so you could just go back to the tried and true. Sometimes that works for patients. The only problem with that is they don't alter the secretion of the hormones. They just kind of mask the symptoms. So sometimes you actually have to go after reducing the hormone secretion. Zofran, ondansetron, guess what? Serotonin blocker, causes constipation, sometimes really helpful. Cyproheptadine, old school antihistamine, sometimes can help with flushing. And there's some post-marketing evidence for telorthistat ethyl, the Zermello, that it can help with flushing. So on that note, we are going to do question and answers.